West Medical Center, Departments of Neurology and Hematology Oncology. Had training both in the center of this country and overseas in England as well, so sort of span the globe. I won't go through the whole list. She's, like I said, the Director of Medical Neuro-Oncology, and is going to tell us about tumor treating fields in glioblastoma multiforme, which is obviously of great importance to some people and is obviously a devastating diagnosis for most people, and we'll be interested to see what new treatment options are available to improve that. So, thank you.
Thank you. So please, at any point, feel free to interrupt because I'm going to talk about something that, interesting enough, is, and I'll go through it, like the FDA approval and the highest category rating by the NCCN, and it's a treatment that pretty much nobody has ever heard of, and it's really impacted survival greatly. So I'm happy to spread the word. So those are my disclosures. I am a consultant and on the Speakers Bureau for the company that actually makes the device. And so this is the title of the talk. So I'll just give you a little bit of the history of it. But the device is called Tumor Treating Fields. That's a generic name of it. And it's electrical field treatment, basically, for the treatment of glioblastoma multiforme. So, and that's my disclosures there. So everybody always wants to know, everybody's, of course, very scared of getting their brain tumor. That's just, from the get-go. Nobody seems to be scared, of dying from their metabolic syndrome, however, which is going to kill, of course, the vast majority of Americans. That we're not as scared of being, diabetes or hypertension, the fact that we don't exercise, that we're overweight, that we have high cholesterol. Nobody's scared of that. So there's, what I tell all my residents too is that there's actual risk and there's perceived risk. So we're all secretly addicted to our cell phones, even though, that we're also secretly worried that it's going to give us brain cancer. And I'm here to tell you that's not the case. I'm also here to sort of relay everybody's fears. The chances of you getting a brain tumor are incredibly rare. So there are about 23 cases a year in the United States, okay? 23,000 cases a year in the United States, population of 300 million people. It's 1 to 2% of all cancer in the United States, okay? So it's very rare. Having said that, about half of those patients end up dying from their tumors, so it does have a slightly high proportion of then cancer death. Primary brain tumors are the third leading cause of death of cancer in men from 15 to 34. So, the men from that age aren't expected to die, so, this is one of the causes that they can die from. The problem we've always had with this diagnosis is from the get-go, about anywhere from 50 to 85% of them are high grade. Okay, so that means sometimes that the horse is already out of the barn and we're trying to chase it down the street and grab it because, as one of my old mentors used to tell me, was that it's basically at the time of diagnosis about a replication cycle and a half away from being a lethal dose, like in the brain, which is basically about sort of like a half a kilo of tissue in the brain. Even today, and I'll talk a little bit about this, but most primary high-grade gliomas recur despite current available treatment. And one of the things I want to emphasize, and emphasize this to my patients, because people always talk about curing cancer. And for solid tumors, whether that's breast cancer, lung cancer, colon cancer, brain cancer, etc. cancer, cures are, if we can treat it, they're treatable conditions, but they're not curable conditions. And the reason why is that there's always a nidus of disease that's left behind, okay? I can't, when brain tumors are diagnosed, even on the, in the 1950s before there were IRBs, the surgeons would biopsy the other side of the brain, and there would be glioma cells there, And we know at the time of diagnosis that enhancing mass that we see in the brain is just the tip of the iceberg. That tumor is throughout the brain. And that's the same thing if whether you have breast cancer. Those ladies have 20-plus year expected survivals. They're getting treated. When I get my referrals, those they have very, they used to have very big charts. Now it's a big electronic medical record that you have to go through to sort out what's been going on with them. But they've been treated for those 20-plus years. And that's because it's very hard to get rid of that last bit of residual disease. When we talk about curing cancer, we're really talking about the liquid tumors. What do I mean by liquid tumors? I mean lymphomas and leukemias, okay, the blood cancers. And anyone want to take a guess about why we can cure the liquid tumors? Because we can take out every single bad cell and give you a whole new bone marrow, right? You can take out your old bone marrow, which has all, maybe residual disease somewhere, and give you a new bone, and that's called bone marrow transplantation. We cannot do brain transplantation, and even if we could, I would not sign up for it because it wouldn't be you anymore. Okay, but this is the issue. In gynong tumors, you could, of course, do double mastectomies. You can do a salpingo oophorectomy. You can remove every, the woman's, or even, in the case, prostate cancer, men's prostate, but for the women especially, and take out every single organ that could be possibly at risk. And they do that, right? So there was a very highly controversial trial at Mayo Clinic where young women who did not have any cancer, but they had the BRCA mutation. They had aunts, they had parents, a mother that died of some type of gynong tumor. So they did a randomized control trial. Half of them got double mastectomies, other half didn't. And it was a highly positive trial. But you don't see women, with BRCA mutations running to go get, having a double mastectomy, a bilateral salpingo oophorectomy. To the point where it's become that those women with those mutations become a very tough choice for that. So Angelina Jolie, wrote a very poignant letter to the New York Times about having just watched her mother die of brain cancer in her 50s, knowing that she had the BRCA mutation. She went ahead and did that, and it was a very tough decision for her. But it's not without its complications too, because then the woman gets put into premature ovarian failure, right? So there's a lot of things with this, and this is one of the reasons why I try and emphasize to all my patients, we can treat your cancer, but we can't cure it. And then it becomes, how do we treat the cancer? This was actually, it's much more than $68,000 now. That was when I first did the slide, but it's not cheap to treat patients. And we know that from, the rising healthcare costs. Everybody wants to know what is their risk factor for brain cancer. There are very few. The main one is cranial irradiation. And they know this from the 1950s in Russia. They would irradiate. This is not just, a lot of people were just tossing around radiation because nobody knew really what it did. In the 1950s, they irradiated the scalp in Russia of children with tinea capitis, which is ringworm of the scalp, which is a fungal infection. The fungus died. These children, some of them immigrated to Israel 10, 15 years later. They were coming down with astrocytomas, meningiomas. I remember in the 90s when I was doing my fellowship, I had a couple of patients that worked on the Manhattan Project. They give you a little clip with the unexposed X-ray film. This was the 1940s, and I asked them what did they do, and when it turned black, they said, they just gave us another one. And I said, how many times did it turn black? They go, at least 6, 7 times. Does anybody know what's a way of getting ionizing radiation besides, heading to Cape Cod, that we're not really even aware of? A lot of people aren't even aware of it, although intellectually maybe you are.
Eating bananas. Running your basement.
Well, radon for sure.
Buying antique plates.
Yeah,
Paint on them.
well, so flying. When you are above the Van Allen belt, you're exposed to ionizing radiation. So I remember I did my fellowship with a general in Fred Hochberg, I don't know if some of you know him, and Jay Leffler, who were that was the head and still is the head of radiation oncology there. They had evidently had this case cohort series of Boston airline pilots that did the Boston-London route, million-milers easily, all of them. And they had a nice increased incidence of all different types of cancers, not just brain cancer. And they went to the FAA, and the FAA said, interesting, next. Because what are they going to do? Let retrofit every plane in the world? It won't fly anymore, right? So these are things that, with business people, you always wonder, any kind of cancer. They can do flight attendants, pilots, all exposed. Right? Head trauma can potentiate meningiomas, but not astrocytomas. There are genetic disorders, tuberous sclerosis, Turcot syndrome, familial. Johns Hopkins tried, because occasionally, lightning strikes twice, and you'll see 2 siblings, or a parent and a child, or some two family members that get a GBM, and they try very hard, and the price of genetic testing has really gone through the basement, so it's much cheaper, but we still haven't found a brain tumor gene. But there are obviously other types of things. Actually, I should put Li-Fraumeni, that's a fairly common one with P53. But these patients have multiple other types of tumors, and brain tumors just ends up being one of their type of tumors. So I tell my patients, because as soon as some of them arrive, their spouse or loved one will say, "Dan, they smoke a lot. Can you get them to quit smoking?" And I'm just like, this is probably not the time to quit smoking when you've just been diagnosed with a GBM. And we can address that later, but it's not ever been done. Alcohol hasn't. Cell phones actually have not, and dietary patterns have not been associated. So the incidence, so in the United States, because of the demographics of the United States, it's a disease of white middle-aged men, okay? And then you get a second peak in, the above 70 group, and that explains John McCain and, Ted Kennedy, okay? And that hasn't changed at all. The features, the presentations, it's fairly protean, about 15 to 20% will get this altered mental status, and it can kind of act like it's a pseudodementia or schizophreniform. And especially in my elderly patients, I'll hear, we just thought, mom or dad was getting, Alzheimer's, but like the Alzheimer's history is like 2 months, so it's a much more rapid course than you'd expect from something like Alzheimer's. Seizures can happen too. They tend to be caught a little bit easier in the lower grade tumors. So the lower grade tumors, how they present, is with seizures because they grow so slowly. There's usually no focal sign, so that's why it's associated with a better prognosis, not because it gives any sort of saving effect at all from just having a seizure. And then headaches are about a third of patients. This was the old classification. This has changed, actually, so now we do more of a genetic classification. The reason why I'm going to go with the old classification, this changed in 2016, was the trial that I'm going to talk about was based on this classification because the trial started in 2010. So what it was for years, and it was just really was a histological diagnosis. Grade 2s, if they showed any nuclear or cytoplasmic atypia, you were grade 2, your survival was 5 to 7 years. If you had a single mitosis, all of a sudden you had anaplastic or grade 3 astrocytoma, and your survival dropped down to basically about 2 years. You had GBM, if you had endothelial proliferation and or necrosis. What is endothelial proliferation or necrosis? The tumor is growing so fast, it outstrips its blood supply. It secretes VEGF. I don't know if some of you have heard of vascular endothelial growth factor. Judah Folkman at Children's Hospital gained a lot of fame for kind of showing this, although it was actually discovered by the chair of pathology at BI. Sort of a Boston little tidbit there. And so, the tumors will secrete VEGF and force the body to supply new blood vessels to feed them. Those blood vessels don't have the normal tight junctions that arteries, do in the brain, which, have a blood-brain barrier and tight junctions. So that's where you get all the leak of the contrast dye. They're growing so fast that even though they're secreting VEGF, they can't still keep up. The blood supply can't keep up with the growth of the tumor, so you get a lot of central necrosis too as well. And that's the harbinger of a GBM. And then back in the day, and now I'm going to show you how our survivals have increased. Since about 2005, the survivals have dramatically actually increased, although it's still obviously not a home run. That back then it was about a year. And now we know there was this oligodendroglial. These are basically astrocytomas, what I'm talking about, but there's now oligodendrogliomas that we know more of the genetics for, which is also glial type tumor, but their survivals they're very treatable tumors, and they do better with their survival just having the oligo component and also being sensitive to treatment, and their survival can go up to years. So I want to show this curve to you because it's amazing to me how people forget this curve in neuro-oncology. This was from Dumas Depart. She was a woman, and that was her hyphenated last name, and she was the head of neuropathology at the Mayo Clinic. And she was a neuropathologist, and she plotted out of about 300 patients, she plotted the survival curve. And this is what I call BT before Temodar. And this was published in the late 80s, nothing has changed in human evolution that this curve will change, okay? If you do not get the 2 FDA-approved therapies for the treatment of this disease, this is your survival. And the reason I bring this up is it's amazing to me, and I can go on about ethics and whatnot, about how patients get triaged away from treatments that have been approved to enter into a clinical trial. Okay, and it's unfortunate, but it is a problem. And so what happens is, if you had a grade 4 tumor, basically half of the patients were dead in a year, and then at 2 years, about 95% of them were dead. We now know that 5% were still alive, were actually most likely these oligos or IDH mutated tumors that actually have a very extended survival. We know that genetics now, and that's why the classification scheme has now changed to include genetics. But those were the only 5% of the patients. So 95% chance of being dead at 2 years. And that would still hold true if you don't get the FDA-approved treatments, which are 2 of them. This is what it looks like. This is something that anybody can take a look at and say, yeah, that's not good. Okay, so, your neurology in the room, or there's, if there's an MRI, right eye, left eye, because you're looking down at us. The white is the fat in the bone marrow in the skull, gray is tissue, black is the air here in the sinuses, the CSF right here in the ventricles. And this is the central necrosis. And this is, the vascular proliferation, the endothelial proliferation that happens. These are, these don't have the normal tight junctions, so the dye leaks out, and it shows the advancing rim of the tumor. But this is just the tip of the iceberg. This is the flare. You can see some of this is edema, but a lot of this is just infiltrating tumor. And really, it's already crossed over and is on the other side. And if you biopsy the other side of the brain, there would be tumor everywhere. Okay, so this is it for FDA-approved treatments. There's really only basically 3, but I'll talk about the third one, which no one really kind of uses anymore. But there's really 2 that work. So back in the 1970s, BCNU is a nitrosourea, and it was approved for palliative treatment. It had no overall survival benefit. It still has no overall survival benefit, but it's amazing to me how people try and combine it with other agents all the time, sometimes also with other agents that have no survival benefit, have been shown to have no, because, if one has no survival benefit and then the second one doesn't have, well, then clearly 2 are going to have some survival benefit. And I've heard this is apocryphal, but it seems like, something I'd hoped Einstein said. But what did Einstein say was the definition of insanity? Allegedly. Do something over and over again and expecting a different result. And I just throw this up there for the residents because I said, you're going to get a trial where they're going to put this in there. And it's already been shown since the 1930s. So the palliative therapy, clearly giving chemo to somebody and it doesn't work. Who are you palliating? You're palliating yourself, right? Oh, I'm helping somebody. But what does the Hippocratic Oath say? Does it say go run out and help everybody? It says do no harm, because even Hippocrates knew thousands of years ago that sometimes well-meaning, you can be well-meaning but cause more harm than good. So I'm not even sure why but it is FDA approved. So if you want to toss it at your patient, you can. So one of the things people said, well, the problem is you have to give it IV. It's just really not penetrating the brain. You're getting a lot of systemic toxicity. So let's put impregnated in, so carmustine and CCNU, which is another nitrosourea. They're very chemically similar. We'll put them in wafers. They look just like Necco wafers, right? And, the surgeon goes in, takes out the tumor, and in the resection cavity, you layer up all these wafers that are impregnated with CCNU. It had a 1-month improvement of overall survival, but there was toxicity in the sense that you're putting chemo directly onto a fresh wound. And a lot of surgeons, Hopkins really pioneered this approach. A lot of the neurosurgeons from Johns Hopkins are very comfortable doing it. When I talk to surgeons in Boston, Brown, New York, they're very uncomfortable because of that small but definite risk of postoperative wound infection. And their idea was, well, if you have a postoperative wound infection, use that 1 month of treatment because you're delaying treatment, trying to give people antibiotics and whatnot. So you won't find a lot of neurosurgeons really liking that unless they were actually trained at Hopkins. Temodar in 2005 came out, and it was a Canadian European trial. It basically ran half of the arm was just radiation alone because the Canadians and Europeans realized that no chemotherapy had ever been shown to help GBM. So why harm someone? So they just gave radiation alone to half the patients, and the other half of the patients had Temodar, which they felt was a radiation sensitizer. It's an alkylating agent. Alkylating agents were known to be radiation sensitizers. Temodar actually was made a little bit more. It's just a carbazine. They made it a little bit more lipophilic so it gets into the brain. They gave it with radiation, the 6 weeks of radiation that we use, and then for 6 months afterwards. And they showed that it more than doubled the 2-year survival, and all of a sudden we had about close to 15% of the patients, sorry, I shouldn't say 50%, about 10% of the patients surviving 5 years, which had never been seen before in the history of GBMs. And just as another little aside, that trial was never run, so it was published in New England Journal of Medicine. It's become the standard of care for GBMs. But America did not participate in that trial because evidently the centers that were considering opening it felt very uncomfortable that the control arm did not have any chemotherapy in it. And of course, as I showed you, there was no chemotherapy that ever worked. So again, there's I think sometimes you're convincing yourself that you're doing something right, when all you're doing is preventing something. So America has never actually participated in a positive chemotherapy trial because since 2005 and before 2005, if you exclude the wafers that most people don't use because of the toxicity, there's only been one chemotherapy that works. So then what happened was Bev came out, which is an anti-VEGF therapy. And I have to say I drank the Bev Kool-Aid, and it made perfect sense to me. If the tumor is growing, and all cancer that's growing so fast, we're going to secrete VEGF, which is vascular endothelial growth factor. We're going to force the body to feed us. Here's a monoclonal antibody that's going to just bind up all that VEGF. We're going to cut off the blood supply to cancer, and those cancers are, by golly, are going to starve and die. And everybody, I think, it was the sexy chemo. It was the sexy chemo of the 2000s. Checkpoint inhibitors have become the current sexy chemo, so you always kind of wonder what's going to happen with that. And so it was when it first came out, approved for GI cancer, for breast cancer, for lung cancer, for brain cancer, and then they started doing the randomized controlled trials. Oh, hi, Mike. And they found that, there was no survival benefit. So it lost breast cancer. It's still hung on to GI cancer. It's hung on to brain cancer because it never improved quantity of life. No, it didn't improve overall survival, but quality of life, because when you cut off those leaky blood vessels in the brain, all the edema goes away. So, and that was one of the reasons they thought initially it worked, because like the MRIs looked fabulous, the patient looked fabulous, and then they found out that they died still at the same time because the tumor was still there growing quietly in the background. And like I told you about the lethal dose of tumor, it still killed people at the same time. So that was and it still is approved, and I call it the $10,000 Decadron, and that's how I use it. I use it because steroids itself, once these people get on steroids, it's hard to get them off steroids. Causes so much morbidity and mortality because of all the side effects from it that I use it to get people off steroids if I can't get it. Then this is the Tumor Treating Fields that was actually approved for recurrent GBMs, and I participated in that trial when I was at Beth Israel. It was like open from about 2004 to about 2008, 2009. I actually in 2006, 2007 participated in the trial, and I put 2 patients on it. And what it was since no treatment had ever been shown and still not shown, to improve the survival for a recurrent GBM, the control arm, the company said, was whatever the physician's best choice was, because there was nothing that anybody had ever shown that had really helped. And then as a monotherapy, Tumor Treating Fields was put in. And what was interesting, it was designed as a superiority trial. There was no difference in the survival curve, so the company went to the FDA and said, well, we want to make it a non-inferiority trial, that we were just as good as anything anybody else could throw at it, but we had less side effects because all you're doing is putting these little pads, and I'll show them to you, on people's head, and they had very little toxicity. And I think me and other investigators and people who didn't participate in the trial didn't take that same message away from the trial that the company did. We said, well, for as much good that we did with chemotherapy in the control arm, we might as well just throw some electrodes on somebody's head and tell them to have a nice day. And I think most people in the country saw this as a failure of current therapy as opposed to success of a new therapy. And it was very interesting. So Roger Stoop, who was the European neuro-oncologist, he was from Switzerland, he was the head of the European Organization for the Research, Treatment, and Cancer, the neuro-oncologist there, he did Temodar. And he also then did Tumor Treating Fields in newly diagnosed GBMs. I'm going to talk about that trial because that's just the second positive trial really in the history of GBMs. And I asked him, Roger, why did you do this? Why were you so, it was a failure in the recurrent setting. He goes, well, Temodar was a failure in the recurrent setting. And he goes, there's the tumor, by that time he thinks, has just become so resistant to treatments, picked up so many mutations. That's not the time to intervene. The time to intervene is when it's newly diagnosed. We thought we saw a signal in the recurrent thing. There were some patients that seemed to have some benefit, so we moved it up. And sure enough, he was right. And I just say that some people just have good instincts, And so he holds the credit for having not only of the 3 positive trials in GBMs of basically 40 years of trying, he's done 2 out of the 3. So this was the Temodar trial, Temodar and radiation, standard therapy in the newly diagnosed GBM. So this added the Temodar to race. And remember the survival curve, okay? Half of the patients are dead, so nothing has changed. This is 2005 when this was reported, right? 1988 when Damar Depart reported her survival curves. Half of the patients were dead in a year, and basically in 2 years about, and this of course is a clinical trial, so you have the best survivors. Hers were of course everybody. You only put people who have the best prognosis into clinical trials. They have to be at least walkie-talkie. So maybe a 10% 2-year survival in the patients that were able to qualify for a clinical trial versus 25%. And there was a tail, and that tail ended up being about 10% in 5 years. There was nobody alive. There was nobody alive who did not receive Temodar in the control arm. And, some people, or if they just get the radiation, only nobody was alive in that arm. So these are some of the molecular markers. I won't spend too much time on this, but these are some things that we're doing to differentiate between the oligodendrogliomas, the low-grade gliomas that have become GBMs but are really very sensitive. This is a marker that assesses the response to Temodar. And what Temodar is, right, it's an alkylating agent. Alkylating agents put methyl groups on DNA. How do you turn on and off genes? In eukaryotic gene expression, you methylate the promoter region. So what alkylating agents do is they come in, they're just randomly putting all these methyl groups on DNA inside the cell. If a cell is dividing, all of a sudden all these cells are, their genes are being turned off. It's a lethal event for the dividing cell, and it dies. But that happens. We're on always. That's how we control our gene expression. We're methylating genes. We're taking off methylation. So there is a repair enzyme called MG. The MT stands for methyltransferase. In patients whose tumors have the gene turned on, that's an unmethylated promoter region for MGMT. Those patients, that gene is turned on. It's unmethylated. It makes the repair enzyme. You give those patients Temodar, they're resistant to the Temodar because Temodar puts on alkylating groups, and this methyltransferase just comes and just takes them all off. If the promoter region for the MGMT is methylated, that gene is turned off. It doesn't make the repair enzyme. That's about 40% of GBM patients. You give the patient the Temodar, and they can't repair the damage, and the tumor dies. Okay, or is more sensitive. It is not 100%. And the reason why it's not 100% because this is a genetic way of classification. You're looking for methylation of a promoter region of a gene. How much methylation has to happen? Which part of the CpG islands in the promoter regions are important in turning that off? Nobody really knows. So there are companies that do these tests, and it's kind of a guesstimate. Oh yeah, that's about what you need to have that gene turn on and off. And I think the error rate is about 10 to 20%, and that's why I think everybody who got Temodar, even with only people that survived, whether or not, because they broke it down at the end when they did the trial of people who were methylated and unmethylated. Even the unmethylated patients, there was about an 8% 5-year survival. Nobody who was unmethylated that got radiation alone was alive, and I think that's the error rate of the test. So what I tell everybody is don't give up something that's been proven for a clinical trial. Because what are they doing now? They're checking to see if you're unmethylated and methylated and saying, oh, you're not sensitive to Temodar. Let's go into this clinical trial that we have. It's a brand new, shiny clinical trial. We're going to give it to you. But remember, 40 years of trying, you have a very large N right at the bottom, and you have a number 3 at the top. When you have a number, like a small number over a very large number, what does that approach, that ratio? 0. Your chance of your next clinical trial being positive is basically approaching 0. And this is what I try and tell people. Do not get triaged away from the only chemotherapy that has been shown to work in GBMs. And you can go through all the data, and if you do, your survival will be what Damar Depart says, or what this original trial showed. That is what your survival is going to be. And I think that's not explained very well to patients. All right, so this is the introduction to Tumor Treating Fields. And most of you have probably never heard about it. And again, this is, problems with the field, where there's a lot of resistance, I think, unfortunately, to new ideas. So this is what it is. They're thought to be an anti-mitotic therapy. So if you remember in mitosis, right, you have metaphase, telophase, and what you're doing is you're making, DNA has doubled, you're making the microtubules, you're making the spindles, the DNA is getting dragged to the center of the cell. the cleavage furrow develops, and then the DNA, the DNA divides in half, the cell divides in half, and it drags the daughter cells get dragged apart, and half of the DNA goes in one, and half it goes in the second. All of that is protein, mediated by proteins. As you remember from your days in the lab, and I'm sure everybody has poured a gel, denatured their protein, and run, you run to red, you run to the negative charge because the proteins are more positively charged, and they're denaturing, they're running. So what happens if you have an electrical field current, and it's an alternating electrical field current, you have your proteins that are positively charged, they're getting pulled like this. So the theory behind this, and actually not a theory, they have a lot of great evidence that shows that this actually works. And that it's, the company before they went into clinical trials in 2005, I mean, they've been researching this since the late 90s. They had a lot of great in vitro as well as in vivo and animal models to show that that mechanism actually works this way. And what happens is you're trying to, create your microtubule spindles, they don't happen. The cleavage furrow never develops, and the cell undergoes apoptosis and dies. And that's what kind of ends up happening in this sort of situation. And this is just kind of a cartoon sort of situation where you have the impacts. So right here, as they, just basically disrupts alignment of the tubulin subunits. It disrupts microtubule spindle formation in metaphase. In telophase, then you're trying to make the cleavage furrow. Again, you're just getting this distortion of the field that's acting on this. And what the reason the company used the brain, because all the cells in the brain are at G0 rest, right? Nothing is dividing in the brain. So the two electrical organs in the body, the heart and the brain, both of them, if you have a heart attack, those cardiac cells are gone, they never come back, right? If you have a stroke, those brain cells, they do not regenerate. If you're a smoker, you stop smoking in 20 years, and if you're a heavy smoker, 20 years, your lung is supposed to regenerate and go back to baseline. If you're an alcoholic and you stop drinking, your liver will regenerate if you do it before you develop cirrhosis. That, once you have a stroke or heart attack, your cells are gone because they're in G0 rest. And that is why brain cancer is very rare. These cells don't like to divide, and cardiac cancer is almost unheard of. These are not cells that divide, right? So this was like the perfect place to test this theory because you're not going to disrupt the normal cells of the brain. And this is I'm just talking a little bit about the utility of electric fields in medicine. These are the biologic effects right here. So if you look at MRI, right here, these are the tumor treating fields, very low energy. It's lower than radio waves, it's lower than microwaves, lower than ultrasound, lower than infrared, lower than UV, X-rays, and this is ionizing radiation right here. These are X-rays. And one of the things that's important right here from the recurrent GBM trial that they did was it seemed like if the patients that responded, it took about 8 months. At 8-month median time to response, because this is a very low energy device. And one of the reasons when they set up the second trial, which I'll talk about, because it takes 8 months, they allow patients to go through a second progression just because they thought there was a lag for the device to kick in. And then I don't think this is going to work because this is actually, and I'm not going to be able to show this to you, but this is. I had to send a PDF of this because it's a pretty huge file. But basically, and you can go to their website, you can look it up yourself. There's petri dishes, one petri dish here, one petri dish there. One petri dish basically has electrical fields. This one doesn't. And it's cancer cells. They're just dividing over and over again here. When you put the electrical fields, barely anything that divides, and anything that tries to divide ends up undergoing apoptosis with membrane blebbing and just dies. Okay, and it was a very, I think, kind of a cool thing to show that, at least in culture this works, and in animal models it also works too as well. The interesting thing about this is the company is not resting on its laurels. They just cut to the chase. They have FDA approval for this device, and the trial ended up being positive. But what's happening is, when you're trying to generate electrical field, it's voltage plus frequency. So they found for GBMs, the cell kill happened at 200 kilohertz. For non-small cell lung cancer, it was 150 kilohertz. For pancreatic cancer, it was 150 kilohertz. The normal intestine is only 50 kilohertz. So the idea being is you could generate this towards the pancreas. You could, and I'll show you how they do it. You can put these pads on the belly, and you would just be targeting, then the pancreatic cancer and the normal intestine would be okay. So they had a positive phase 2 in pancreatic cancer. So they're doing the phase 3 internationally. The phase 2 was in Europe. We're doing a non-small cell lung cancer trial right now at Tufts, and we have the brain mets for lung cancer trial too as well. They're running an ovarian cancer trial too as well. So they're not resting on their laurels. And they already had actually their first positive last year for mesothelioma. They had a positive mesothelioma trial, and the FDA approved that. So they're branching out into other cancers, and so hopefully more people will start hearing about it. But this is what it looks like. So it's basically 4 pads. You wear it right front, back, right, left. They have to be wide enough to generate enough of electrical field. The pads have to be large, and that's one of the things about it. And there's 9 ceramic electrodes in here. There's like a conductive gel that happens. It connects up to this transducer. It goes into this device that has a battery, but it also has a computer. And what happens if you connect this up like this gentleman does over here, and it's a 2.5-pound device currently. For the trial, it was 6 pounds. So when they came out with the 2nd generation device, I told my patients, you just went from your Dell laptop to your MacBook Air. And they, the people who were on the trial liked this a lot better. But one of the things is it creates a circuit that's recorded in the computer. So I know every month how much my patients use it. And we knew for the trial. So, and they found out also for the recurrent GBM trial, the people that seemed to do well were wearing it 18 hours a day. Why do you need to wear it 18 hours a day? Because there's no half-life. It's electricity, right? If I flip that switch, these lights are gone. It doesn't linger. So if you don't wear it, there's no electrical field, it doesn't work. So you have to shave your head and you have to wear it 18 hours a day minimum. And so it was a huge ask, of patients. And what was interesting, physicians had a harder time with it, and I think a lot of medical oncologists were coming from biology. We're not really coming from the physical sciences. Being in Boston, I have MIT patients. They're all over this. They're like, oh yeah, that sounds really great. Sign me up. Patients were much more interested in this, I have to say, than I think a lot of physicians were, including me, because they've always been interested in alternative treatments. They don't want surgery. They don't want radiation. They don't want chemo. But this is something that you just shave your head, put these things around, you walk around with this thing, you do it yourself at home. And I remember my nurse practitioner, Nadine, who Mike will probably remember, said when this trial, when Jesu, who was a neuro-oncologist, several neuro-oncologists before me at Tufts, opened this trial, she was aghast. She was like, oh my God, I'm going to get, she's the nurse practitioner, I'm going to get phone calls every single day from all these patients about everything. And she said of all the trials that he opened, this generated the least questions, because the technician just showed them how to do it. You just shave your head, you put this on, maybe there's a skin rash, you put some lotions on, that's it, and you walk around with it. There was nothing. There was no nausea, vomiting. You don't have to get blood drawn. There was nothing. And that was one of the things about it. It's cosmetic, and there's a rash. And those are the main side effects. And the other thing about it is because you can adjust the angle of the rays, you can direct it towards a thing. And we're going to be coming out with a paper here pretty soon, because I was always interested in how they were relapsing. So and I wasn't the only one, some of the other investigators did too, how these patients were sort of relapsing. And we did find that there's a way we figured out of figuring out the intensity of the field. And the patients that had more of the field, they had a greater chance of local control. Where the field was weak, that was usually where the tumors came back. So it's a low intensity radiation. It is a radiation, but it does seem to act like ionizing radiation is that you can direct the field, and then you can target this tumor, and then get some better local control and help you with preventing this tumor from coming back. So this is the data. So it was a very simple trial. So there's a lot, and what was interesting to me about this trial when this came out, being an investigator, so it was published in JAMA in 2015. There's politics about this as there were politics about everything, and I guess everything that we do in the world, unfortunately. But it was interesting. So it was, of course, this is like, only the 3rd positive trial in brain tumors in the history of brain tumors. You'd think it would be a slam dunk for the New England Journal of Medicine. But there was evidently 3 reviewers, and one reviewer was very resistant to this whole idea of electrical fields. And I have to say, as an oncologist, the crap that's sometimes published in New England Journal of Medicine, some rubbish phase 2 trial, I was shocked that this wasn't. But they went to JAMA, and JAMA took it very easily. So this is it. This is the STUP protocol where they do 6 weeks of radiation with Temodar. That's now become standard of care. Everybody should get this. Don't triage your patients away from this. Then they did everybody got the 6 months of adjuvant Temodar, which was the STUP protocol from 2005, the only chemotherapy that's ever been shown to be positive in GBMs ever in 40 years of trying. And then because it takes 8 months, this is the electrical field therapy, it takes 8 months of median time to response, they allowed people to go past a first progression to a second progression. You were not allowed, there was no crossover allowed in the trial, but remember it was already approved for recurrent GBMs. Some patients, and it ended up being about, I think 18 patients in the control arm actually did switch over. That was considered a major protocol deviation, and it was treated as a major protocol deviation. And then they stratified based on amount of resection, which was a known prognosticator, and then the sensitivity to Temodar. They stratified based on that too. And this was it, so it was interesting. So in Roger Stup, who's the neuro-oncologist that I was talking about, his original trial was with Temodar, and it was like 18 to 70. That was his cutoff. He cut people off at 70 years old. And 10 years later, he came out with this trial, and I think he started thinking, he was probably maybe closer to 60 at that point, and he started realizing that, 70 is not that old. And so the second trial that he did was greater than 18. And what I want to tell people is don't be an ageist. Give people the treatment. It's amazing to me how sometimes 70-year-olds want to live just as much as a 69-year-old. And so just realize that don't cut it off. And the reason I bring it up, because again, the 18 to 70, and Mike will remember this because I told the fellows that there were other places in Boston, and I won't tell who they were, but they were Dana-Farber, but where they would tell patients at Mass General, which is my old fellowship, that if you're over the age of 70, Temodar has not been shown to work for you, so don't take Temodar if you're over the age of 70. And then Julie Fu, who Mike remembers very well, was texting me from ASCO. This is an ASCO plenary session. This is the status of neuro-oncology in the world. In 2016, an ASCO plenary section was, lo and behold, we're going to look at a randomized controlled trial in people over the age of 70 and see if Temodar works. And Julie Fu is our fellow who's now at Stoneham. And she's texting me. She goes, oh my God, Dr. J, what do you think? I go, was it positive? She goes, oh yeah, it was positive. Because Temodar works in people over the age of 72. It was a plenary session. And the next session was, reinventing the wheel too as well. But what do you do? It's just amazing to me. But so this is what, so don't be an ageist. Everybody should get Temodar. This is the performance status. You have to be walkie-talkie to get into a clinical trial. And you need to be able to live a little bit more, and then you couldn't have any of these things, which is infratentorial. So what happened was, this is brainstem tumors. At the time, they couldn't figure out how to put the electrical fields, so it would have to be over the patient's mouth to cover the brainstem. Now the physicists have worked it out, so now we can actually treat infratentorial tumor, but at the time, they didn't allow that in. And so it was very simple, it was randomized, it was like a simple 2-to-1 randomization. After radiation, they would get it. They didn't do it with radiation just because they weren't sure how the fields would affect with radiation, and they didn't want to interfere with radiation. So 1,000 people were actually signed informed consent. So if you're doing your clinical trial, you have to expect that you're just going to need a lot more patients than you think. 700 patients, which is what they wanted, basically were randomized. 466 got the fields, and then 229 didn't. And these were their screen fails. Okay, this is just showing that they were pretty well matched. Again, in the United States and in the world, because this was an international trial, it's a disease of middle-aged men. In the United States, it's white middle-aged men because of demographics, that had a good performance status, and this is just some of the other characteristics. They did match based on sensitivity to Temodar, and they matched based on the amount of resection, because these are independent prognostic factors. This was shown to be a marker of the low-grade tumors. This was the one in the Demar-Depart curves. These are the 5% of patients that just kept on living, and that ended up kind of basically being matched, about 5 to 7% too as well, and just by random. It wasn't stratified, it just ended up being about the same. And what was interesting, this was initial, this just shows how many patients completed the standard treatment. It was interesting, the people that got the electrical fields, this was an early indicator that they were doing better. They were most of them managed to get through their 6 cycles of Temodar, not so much the patients that got the Temodar alone. Okay. And this was so this was the 5-year update, and this was, again, published in JAMA too as well. This was Temodar alone. This is, the Kaplan-Meier survival curve. This is what you want to see. And you want to see a shift to the right. and this is the progression-free survival if you got the fields. And it led to basically almost about a 3-month improvement of progression-free survival. The hazard ratio was 0.63, and the p-value was incredibly positive. When you looked at overall survival, the median went from 16 months to 21 months, so it's about a 5-month improvement. And I think I want to show you the 5-year right over here. Who would have thought? Like, remember Tumor depart? Pretty much everybody was dead at 2 years. And so when I hear people stand on national stages and say, we have done nothing in the last 15, 20 years to improve the survival of GBMs, I'm like, that's probably because you're triaging people away from Temodar and you don't talk to them about tumor treating fields, because then you're here. But this is what we've done. So this should be basically standard of care for the treatment of these patients. Another thing, so Roger Stoop, because people really are having a hard time, I think, wrapping their head around the fact that electrical fields work. And Roger Stoop said his hazard ratio reduction to 0.63 is the same that Temodar did. Temodar had a hazard ratio reduction to 0.632. So he's really, trying to struggle with why this has not caught on as much as chemo has caught on. And I think it's just because people, it's what people are familiar with. They're familiar with chemo, but this is kind of out of the box thinking. This was the annual survival. So when you look at every single time, the 5-year survival in this one was about 5%. In his original trial, it was more like about 11, 12%. But here, it's what you randomized to your control arm. It was about 13%, so triple the 5-year survival. And you can see it added on to almost 50% of the people were alive at 2 years. Remember, Tumor depart, 5% should be alive at 2 years. So huge improvement in the 2-year survival. This was the subgroup analysis, of patients. It didn't matter whether you were sensitive to Temodar or not. You did the same, and it shouldn't, right? Because it's not an alkylating agent. It's electrical fields and anti-mitotic treatment. Methylation should not matter. What was interesting is Carl Hyman, and I don't know how many people know Carl Hyman. He's the chair of neurosurgery at Tufts Medical Center. And he says, Surya, this is such a low energy thing. It probably has, I think it's going to really help those patients that have a gross toll resection and there's just microscopic disease. It's going to be able to keep those quiescent cells quiescent, is what he told me. And lo and behold, the people who had the biopsy had the best effect size. You can see that. Now they still did worse than, their survival was worse than the people who had a gross toll resection. But it shows that even if you have a big honking tumor, you saw the picture, that's usually what a GBM looks like. It's usually a nasty thing. They actually did the best because those patients end up dying, pretty quickly because they just have a huge tumor burden to begin with. This is another thing I like to tell people. About 16% of patients on this trial were older patients, seniors, over 65. Look at their effect size. Okay. Again, their survival was lower than the younger people, but they really benefit from this. And so I usually emphasize, do not be an ageist. One of our best patients was a Jesuit. For some reason, Tufts has a connection with the Jesuit priests. We enrolled 3 Jesuit priests into the trial. We had 17 patients. All 3, by the way, were randomized to the treatment arm. So if you want to think about divine intervention, you can think about that. But all 3 were randomized. It was a 2-to-1 randomization. So you can think about the odds of that actually happening. And all 3 did very well. But the person who did one of the best, he did it for 2 years. He's a definition of a single man, right, being a Jesuit priest. He was 74 when he entered the trial, 76 when he stopped it. He said, it just doesn't fit my lifestyle, Dr. J, because I'm standing at a podium and the alarm starts triggering because the battery's going low, and it just wasn't my lifestyle. And so he decided he was going to take it off after 2 years. But that was, you can do it if you're an older person and you're living by yourself and you're single. And it didn't matter if you're a man or a woman, and it shouldn't matter whether you're a man or a woman either. Everybody always wants to know what safety is like too as well. So, it's just electrical field, these pads, 3M makes the pads. It's like putting EKG strips on your head, but bigger ones. There was no difference between, toxicity, all the toxicity, the heme toxicity was from the Temodar. There was no increase really in fatigue, and you wouldn't expect anything. There's a medical device site reaction, which was the dermatitis, and that definitely, you didn't see that in the Temodar alone arm. So a lot of people were sort of saying psychiatric disorders. People were sort of saying, well, this is very cosmetic. if they're going to they're just, people are going to walk around with this thing on their head and people are going to point at them and laugh at them, or they're going to feel really bad about themselves. And when they looked at the psychiatric, there was really no difference between, whether you got Temodar alone or whether you did not. There was no difference. They were wondering about increase in seizures because this electrical field. Are you going to just stimulate the brain to have more seizures? That didn't happen too as well. I should have actually said too, I don't know why I don't have it, it's about 50% of patients did get a rash to this. So that was the medical device side reaction. So the other thing I wanted to show right here is compliance with the tumor treating fields thing. So if you think about it, right, if this works, there should be a dose response curve, right? The less, the more you use it, the more it should work, right? And I know exactly, my patients, I know 75% is a good marker. So at the end of every month, if I see my patients drop down to 50% of the time, I have my nurse practitioner give them a call up and say, hey, what's going on? Why are you dropping your SIDS? There should be a dose response curve. And that's exactly what happened here. So they were able to know from the trial if you're using it less than 30% of the time, 35, 50%, 60, 70, 80%. And look at that dose. So this is for the progression-free survival, and this is for the overall survival. Okay? The more you used it, the better you did. So that's a dose response curve when they looked at that. And it became an independent prognosticator that this was the hazard ratio. If you had compliance or using it more than 75% of the time, which was 18 hours a day, you did better. And this I thought was really interesting. So some patients, I have one of these patients, it was about 10% of the patients, and one of my patients who's still alive 10 years out, he drove down from Canada. Jesu actually entered him, he was the first person that they entered in the trial, drove down from Montreal. It was not available in Montreal, in Canada. It's still not FDA or whatever their approval is in Canada. And he finally came out of the closet and went to a Montreal radio station or TV station and talked about how, 9 years later with the GBM, he's still alive. He's the only patient of our 17 patients that never took the device off his head, and he's actually the only person that's still alive, okay? Because everybody else took it off their head, and for whatever reasons. One person wanted to put it back on, and he went back a couple more years. But this is what it was. Look at that huge bump in survival to 28.7. Remember, it was 20 months, so they went another 9 months for overall survival. But look at this. Look at their annual survivals compared to the people who got the control arm. And what I thought was very interesting, and this is what happened to him. At 3 years, he was 30%. At 3 years, it was a 30% survival. 4 years, it was a 30% survival. 5 years, it was a 30% survival. They plateaued, and that's what he's done. He's still going. So clearly it's done something that it's that for some reason there's that subgroup, and there was of course 43 patients, but I have to say one of those 43 patients is our patient of our 17, and they plateaued out. And so I tell people, you've got about a third chance of going if you use this more than 90% of the time based on the trial. But I can tell maybe at 3 years that you're just going to be one of these ones. And that's what I've seen, and when I've used in the commercial setting, when I can get people out to about 3 years, they seem to coast a bit, which, again, never heard of with the GBM. And I think the thing is, it helps keep these quiescent cells quiescent. If they try and divide, the electrical fields kick in and take them out. And this is the European Organization for Research, Treatment, in Cancer. These are the instruments that they devised to test people for cognitive function, emotional function, physical function, role functioning, and it was the same whether you got Temodar or not. Okay, it didn't matter if you got the device or not, if you just got the Temodar. Then, because as you know, when we have our patients in the room, they say something and we look at the spouse and say, so is that your feeling too? Is that what's going on? And the spouse usually immediately rats them out if they disagree, right, about how they're really. This is the healthcare provider reported. This is their, how they think that they're doing at baseline compared to Temodar, and this was the patient reported. So you can see that they were pretty equivalent. That not only did the patient feel that they were doing just as well as the people in the control arm, that there was no adverse effect of having this device on their head. And I'm not going to go through too much about that. But what I wanted to do is say that, my conclusions from this is that, that it significantly prolongs progression-free survival and overall survival. Landmark survivals at 3, 4, and 5 years. All subgroups benefited from this treatment, do not be an ageist. Do not, say, oh, they have a huge tumor. They're not. Just, try it on everybody. The toxicity is limited to local skin irritations. It should be the standard of care as part of the standard of care, and I'm surprised that this is not. And it proves the concept of tumor treating fields as a novel cancer treatment. This has never been done before, and they proved it. They just got FDA approved for mesothelioma, and you'll probably be hearing more about it for pancreatic cancer, ovarian cancer, lung cancer, and brain mets from lung cancer next so many years. So, so immediately, so of course it was initially published in JAMA, and I'm not sure you can see it, but Jay Zhu, who was the original investigator, and Lynn Taylor were one of the co-authors from Tufts Medical Center on this trial. These are the landmark papers, December 2015, and the other papers that came out. When you're doing cancer treatment, you would love to be part of something that changes the NCCN guidelines, right? So the NCCN guidelines, the National Cancer Comprehensive Network, these are put out by the National Cancer Institute. They have panels of experts that say this is a Category 1 designation. And when the 5-year survivals came out, they now said it didn't matter, if you're less than 70 years old, whether you're methylated or unmethylated for a GBM, you should consider alternating electrical field therapy as a Category 1. So this came out in January 2018. It is not only FDA approved, but it has the highest recommendation, Class 1 basic Category 1 designation from the NCCN as part of the standard of care for GBMs. And then again, they're not being ageist either. They proved it for that if you're greater than 70 years old too as well, that you should consider this too to be part of your treatment. So I was very fortunate because of my participation in this thing. I was invited to give a talk at the NIH. That was very nice. But what was nice was when I got the announcement of my thing, Michael, this was my name down here. I became a one-name entity, like Cher or Madonna. It was Dr. Surya. And then somehow I got demoted to being a neurosurgeon, But so I sent a little gentle email like, well, my last name is this, and I'm not a neurosurgeon. I'm a neuro-oncologist. But it was very nice to be asked. But, Mike, I didn't know I had become, so world-renowned. One word. But here it was. So it doesn't take a village to run a clinical trial. It takes a world to run a positive phase 3 clinical trial. So it was 3 continents, 12 countries, 83 sites. This was South Korea. These are the Canadian sites. This was the United States of America. Here was Tufts Medical Center, Jay Zhu, Joachim Nystrom, Lynn Taylor. I think they just couldn't fit my name on there. I actually closed the trial. I came in right at the end. I think SJ Apollon would have just been too much, so they left my name off that, which was okay. And then there was Europe and Israel too as well, with the participants. So basically, hopefully this is, I hope I've convinced you that prognosis for this, disease is improving because of new treatment options, that TTS is a novel, regional, non-invasive antimitotic treatment. It is FDA approved. The greater than 22 years is just the weirdness about medical devices. They have to be greater than 22 years. We have used it in children. We've gotten approval, and we've used it in children in the floating hospital. And at the time when I made this slide, over 10,000 patients have been treated worldwide. Also, like Mike, I don't know if this is my son, so I should give an update on him too as well. He was, in National Geographic as Explorer of the Year, and his little sister was also there too as well. So that's the end. So if you guys have